Hello, and welcome to Dermatology Weekly, the official podcast of MDedge Dermatology, where we discuss issues that most affect the specialty. I'm MDedge editor Elizabeth Mishkati. Now, your host for this episode, Dr. Vincent DeLeo.
Today, we're talking to Dr. George Hahn about teledermatology reimbursement during COVID-19 pandemic. Dr. Hahn is from the Icahn School of Medicine at Mount Sinai in New York City. Thanks for being with us today, Dr. Hahn.
Thank you for having me.
So let's get started. Before the COVID-19 pandemic, telemedicine was largely underutilized in dermatology. What were some of the pitfalls that kept it from being more widely instrumental at that time?
That's a very interesting question because I think it's a rather complicated answer. A group of us, members of the AAD Task Force on Teledermatology, sent out a survey to the membership, and we got back a robust number of responses. And it seems like before the pandemic, the utilization of telemedicine in dermatology was under 15%. Mostly at academic institutions and not as widespread as you might think. I think a lot of factors that drove that probably relate to the fact that there's a relative shortage of dermatology in the country already. So most places you open up a dermatology practice and you can get busy right away and see in-person patients. And so the drive to innovate and offer some kind of new technology for your patients, there really wasn't anything driving that at that time. And of course, a global pandemic hits and all of a sudden people are locked down. You kind of are forced to innovate at that time. And that's exactly what we saw with the survey, that since the COVID pandemic started, 97% of dermatologists, so going from under 15 to almost 100% of dermatologists were offering some sort of telemedicine. That really shows you what that kind of pressure provides on a field. I think some other studies were done looking at the fact that, of course, we're able to make up some of the gaps that we lost during the pandemic, but it certainly didn't make up for the volume that we were able to see in person. There's been a lot of challenges with the technology, with fuzzy, iPhone videos and people not really being able to tell what's going on. So I think there's still some innovation that needs to be done to make this sustainable. But at least the attitudes of dermatologists seems to be positive, in that over half of the people who responded to the survey indicated that they were planning on continuing to offer teledermatology in the future.
That's amazing. That data, they're just amazing. After the COVID-19 was officially declared a public health emergency, the Centers for Medicare and Medicaid Services were able to make significant changes with regard to reimbursement for telehealth. Can you outline some of the most important waivers that have been implemented over the course of the pandemic?
Yes, and they played a large role in the adoption of telemedicine overall, just in medicine, not just dermatology. I think the most important thing probably to think about from the Medicare standpoint, from the government payers, is that it used to be that you actually had to have a specific waiver to provide telehealth. And there was two parts to it, both an originating site requirement and a geographic requirement. So the former of those two, the originating site requirement, required that the patient either be in a doctor's office, a hospital, or a skilled nursing facility to receive any kind of care. So you couldn't provide care to your patients in their own home because that wasn't an appropriate originating site. The other part of it was the geographic requirement, which required that patients were in certain rural areas designated as medically underserved. So that right away knocks out a lot of the country. But in addition to that, you actually had to apply for it and get a specific waiver. So, needless to say, it wasn't really widely utilized at that time. Both of these definitely went away with the pandemic. So that's one of the nice things, that we're able to now see anybody and see them in their own homes. Other waivers relate to the fact that now you can see new patients in addition to established patients. So it used to be that it had to be a patient you had met initially in person that you could follow up from remotely, but you could see new patients also. And other more technical details, such as trying to allow for patients who don't have access to two-way live audio video communication to be able to participate in a telephone visit and get reimbursed at levels more similar to an established patient visit. So there have been some flexibilities, not to mention the fact that we're now allowed to use non-HIPAA compliant modalities to contact patients, so that they basically tried to remove any barrier to care that they could. And I think they should be commended for doing an admirable job on that.
And that's amazing. And certainly with government payers, that was in place. How have the insurance carriers, other than the government, responded to these changes?
They've mostly followed, in step with the government regulations and the plans set forth by CMS. It would interest a lot of people to know that actually the insurance coverage for telemedicine before COVID was already pretty strong. We were seeing patients through telemedicine for commercial carriers for years now, and just at much lower volumes and numbers than we do see now after COVID. But most of the insurance carriers were paying comparable rates to in-person visits for those visits already. What has been especially confusing, though, for the commercial carriers is some of them have followed the actual coding guidelines from CMS and some haven't, in that you have to have a specific place of service, specific modifiers. That has changed through the pandemic. And so now you have different policies that aren't necessarily the same as each other. So that's why we always told people that you really need to make sure your billers are contacting the carriers themselves to make sure how you're supposed to bill for the visits, what kind of visit you're supposed to bill for, especially for the telephone visits. For example, some carriers have you use the telephone code and some have you use the established visit code and just indicate that it was a telephone visit. Some of them have different policies on the place of service code. Some of them require a modifier and some don't. So as long as you make sure you're in line with what your specific carriers are requesting, which you should keep in mind that can be different, then you should be doing okay.
So in your article, you also addressed the long-term forecast for telemedicine beyond COVID-19. Let's keep our fingers crossed. What reimbursement waivers will not extend beyond the pandemic?
Yeah, there's a lot of interesting, both political and financial considerations to take into account to answer this question. It's actually really timely because literally last week I got an email noting that Empire Blue Cross Blue Shield indicated that they are now going to reimburse telemedicine visits at 20% lower than in-person rates. That's what we are all kind of afraid was going to happen at some point. Because even in states where there's a telemedicine parity law, meaning that insurance carriers have to cover telemedicine, there's no requirement about the amount that they cover it under. So there's nothing to say that an insurance carrier couldn't go forward and say, I'm going to cut it 20%, I'm going to cut it 50%. How they justify this, maybe they might say that you have less overhead costs for telemedicine, you don't have to pay for space or things like that. But that's going to be a major challenge, especially if other insurance carriers start to follow suit and similarly reduce their reimbursements for telemedicine visits. Part of the appeal for telemedicine is that patient who presents with a rash, we could either avoid having to do an in-person visit to begin with and really save everybody time and money in that front, or B, we actually could prevent that patient from having to go to an urgent care center or even an emergency room to triage this problem that we could have taken care of via telemedicine. So I think there are some benefits financially to telemedicine that perhaps you really have to take a look at the big picture to see. But we'll see how that plays out. I think what's really important from the CMS standpoint is that those waivers, the big waivers we talked about initially, the originating site and geographic waivers, the CMS has the authority during a public health emergency to waive those requirements, meaning that they can say, okay, during the emergency, you're able to see patients outside of this scope of practice that we had established previously. However, once the public health emergency ends, they don't have the statutory authority to make that permanent. So it will take an act of Congress to make that permanent. The good news is that for the most part, the political attitude towards expanding telemedicine. And I would say that's especially true in our state in New York, where the governor has come on record saying that he supports expansion of telemedicine. The political climate towards it seems to be pretty positive. And there are a number of bills that have been introduced already that seek to make these changes permanent and actually expand on some of that access. I think what we'll really be looking out for is whether any of these bills really have a line in there about a reimbursement parity, because that's going to be, I think, the key to making sure that telemedicine survives and can thrive. Because if you don't have that, we're going to enter back, into that state where dermatologists are going to just be comfortable seeing patients in their offices, and why really push the envelope? And I think it's a missed opportunity, because to me, telemedicine really represents the opportunity to make a dent in access to care, right? Expanding access to care, especially in underserved areas, in places where a lot of people have barriers, people of lower socioeconomic status, skin of color. There's a lot of populations out there where we're just not able to get the level of coverage and access to dermatologic care that we want. And I think telemedicine, if deployed appropriately, I'm talking about robust remote clinics, setting up good supervisory models for different either residents or advanced care practitioners. There's a lot of ways we can do this right, and I think hopefully the regulations and guidelines will support that.
Great. Let's shift gears a bit. How does better technology play into addressing some of the concerns about the longevity of teledermatology?
That's a good question, because I would think that probably most of the people who are listening to this who have delved into the world of teledermatology have some horror stories about, either the video signal was so choppy that you're basically looking at like 5 big pixels on your screen and trying to make a decision, or there's times where the patients are tilting their camera and trying to show you an obscure part of their body and basically showing everything else in the process except for that. We've all been kind of challenged with a set of technology that's not been developed for dermatology, meaning for most, let's say, primary care providers, telemedicine is big in psychiatry. There's some fields where you just don't need a high quality image to make your diagnosis or to appropriately counsel your patients. I think that's very different, obviously, with teledermatology. And so when you reach that patient through a video visit, which a lot of us are doing because that's where the payment seems to be the best, you're really missing out a lot that you could capture even just with a simple image. And even with the simple images, it's not always easy to receive it from your patients. You often end up with a compressed image as well. For example, in our EMR system, I had to bring to the attention of our IT team that there's a configuration that you can set that sets how much the images are compressed. And I only found this out by using another hospital's EMR system and wondering why their pictures look so much better than ours. So there's a lot going on in the back end that we're not seeing. And then compounding that problem is the fact that we haven't innovated on our image capture technology much. We're just relying and hoping that people have good enough cameras on their smart devices to take good images. But a lot of times we still end up with blurry images that are out of focus. And you can't really count on your patients to send you good images. Sometimes I really look at the pictures my patients send and I wonder, did you really look at this and think that I could make an adequate decision from this blurry picture that you sent me? So there turns out to be technology that can pretty easily solve for out of focus, for blurring issues, for motion artifacts, even for just recreating poses where you can get a reliable way to capture images from one time point to another so you can compare what's going on rather than just kind of winging it. So I think that is something I'm looking forward to. Also, one big issue that we haven't tackled yet is skin of color imaging. And a lot of times what we find is that, especially in skin of color, you're taking images and they're all really very monotonous. And we have to realize that something that's actually kind of built into our cameras, that they're not optimized for taking those kinds of images. So that's something that I think with technology and better workflows, we'll be able to tackle that problem too. So a lot of issues that we can solve. They seem kind of simple, but I think that we really haven't done what we need to yet in terms of that. And so hopefully that'll help us. There's a lot of companies on the market also who are in the remote clinic landscape, where you can actually set up a clinic remotely, and you'll have access to much better technology and cameras that you can actually make good diagnoses. You can control the camera, pan, tilt, zoom. We were playing around with one of these devices in our resident clinic, and it was just pretty amazing the level of clarity and detail you can get. So I think technology is out there. The costs are still somewhat high, so hopefully those will come down. But I think the future is bright for teledermatology.
Dr. Hahn, your extensive knowledge and passion for teledermatology is laudable. But what can a dermatologist who's out there in private practice do to better position themselves for keeping telemedicine active in their office?
I think that it's important that we keep in mind that there's a couple of factors that are going to drive telemedicine no matter what. And one major one is that patients like it. Patients have now been exposed to it in large numbers, and they're going to expect it and demand it. So if you're not giving those services and you're not offering these services, they're going to go online. And now there's direct to consumer telemedicine platforms popping up left and right. So these patients can go on with their acne, with their skin concerns, with their eczema, and basically what they're being sold online is that their information will be transferred to an expert, and then they'll get a treatment plan and prescriptions delivered straight to them. And so we have to be cognizant that this is the world we live in. And if you don't tackle that head on, I think what we're going to run the risk of is we're, number one, going to lose control of our specialty in a lot of ways. We're going to lose it to these enterprising companies who may not have the best skincare and dermatologic expertise in mind. We're going to lose a lot of patients to that, and we're going to end up picking up the pieces and cleaning up the messes that they create. And that's not really a good situation for us to be in. So I think by taking a more proactive role and really offering our patients the convenience of a remote visit, especially for follow-up, you're going to be helping maintain your practice. There's a lot of benefits that can be had with cosmetic follow-ups. You could do quick check-ins. Patients like that. They love not having to come in. A lot of times they won't need a touch-up and they just want you to talk to them. So that's really beneficial as well through that point. And the last point I'll make is, again, that access to care, right? So being able to provide real access to patients who otherwise would have to wait 6 months and drive 3 hours to see a dermatologist. We have the technology to make a dent in that. And I think as a specialty, some of that burden should fall on us to deliver those models of care that will solve that problem.
George, we really want to thank you for joining us today and giving us your time. Any final thoughts that you might have?
Yeah, I think that we are now using telemedicine in somewhat imperfect and jury-rigged ways. And I hear a lot of frustration out there. I hear people kind of pining for the way things are. And I think, we have to be realistic. Things are never going to be exactly the same as they were. And if we can embrace the challenges and instead of complaining about it, actually do something about it, I think we're going to make our specialty better for everybody.
Again, thanks very much. And I recommend that all of our listeners go in and read in greater detail Dr. Hahn's article. Thanks so much, George.
Thank you.
That's it for this week's episode of Dermatology Weekly. The peer-to-peer portion of the show is produced by MDedge editor Melissa Sears and editor Alicia Saunders. All of our podcasts are produced by Nick Andrews and MDedge editor Kathy Scarbeck. I'm MDedge editor Elizabeth Mishkati, and this is Dermatology Weekly.